Welcome to Health Stealth Radio, where we move away from the mundane to gather insights from the shadows of enterprise and patient cybersecurity. Yes, we surely believe that traditional themes like endpoint software and zero trust are critical, but given massive advances in AI, remote and wearable device hacking, and data hostage negotiators, there's a much darker side to cybersecurity, and not everyone is quite willing to talk about it in public. Health Stealth Radio will thrive on these topics and encourage fireside spats to debate them. Here's your host, Frank Cutitta.
Good afternoon and welcome to Health Stealth Radio. I have the great pleasure and honor of having my friend Al Villarin with us today. He is the CMIO at Nuvance, and they're also going through some interesting changes there. I wanted to speak with Al because we talk a lot about cybersecurity on this show. We also talk a lot about equity, and we talk a lot about what's happening in devices and in applications in terms of things that are inequitable. And we use the term tequity, and I know Al's been very active in that community as well with some of the work we've done in the past. So Al, I'd like you to just take a minute to introduce yourself. Talk to me a little bit about a day in the life of Al as CMIO, what you're doing there. And also, I know from previous conversations that you, as part of your personal branding exercise, you took graduate courses while working on your MBA. I'm just curious what somebody that's got a CMIO background gets from adding to their multidimensional aspects from an MBA course that you didn't have before you took it.
Well, Frank, it's a pleasure to be here. Thank you very much for the opportunity to come and speak to you all. The background is just always had an interest in computers since emergency physician years ago. I went through the residency program, got a board certification back then, and then in practice, we were sitting around the common area with the nursing and the clinician saying, how do we get information? It's all the way over there. We point to the wall where the bookshelves were to find out, what we need to learn about. And we didn't bring it to the bedside. So the first question, I'm sure a lot of us at the time who were interested in merging the computers and healthcare felt that it's going to happen. We have to bring it to make it more efficient for the clinicians to take better care of our patients. That theme has perpetuated through the years of every 10 years or so, growing a new understanding of how important it is to have information by the bedside. We'll get back to that in a second. Mm-hmm. But back then in 2005, 2006, there wasn't a CMIO. It was a informatics kind of person who knew computers and was trained in medical practice. So merging that one person and having two responsibilities created the environment to support others who aren't technically inclined to provide them the guidance they needed for better care of their patients by accessing information. I took it on myself to just create a small website using Front Page from Microsoft back then. And we had a small server in our location, created Front Page. And I just created web pages of clinical information and linked everything, a call schedule, just a basic source of information. So now anyone, anywhere in the ED can go to a computer, click on the website and access, everything we need. So it was very simple, and then we could launch other dynamics outside of within the network, but to our library to get further information as well. So it was the early days of collaborating information for our care of our patients. For me personally, that became a spark. Well, I really want to do this. So I asked around, what am I doing? Is there qualifications around this? How is there work to do it? So at the time, there was a consulting group that was making the rounds in the country and came to our site, "Are you interested in learning more about CMIOs?" I'm like, sure. And there was another person and I at the time doing so. And we learned. And I really found it amazing that how much more interested I was after learning about the CMIO does, and then created that as my career path. So I went from full-time ED to half-time ED to full-time IT over the course of the last 20 years. So that process is continuing. And then today, I always felt that knowledge is something you have to go get. You can't sit back on, being graduated from med school, I'm going to say 25 years ago, 30 years ago, and assume everything today is exactly the way you learned it back then. You have to continue doing so. So I started my master's in medical informatics from Northwestern. I saw a proposal I've submitted. I have to finish my final my project for them so I can get that degree. But recently, last 2 years, I've also embedded myself in the MBA program. And the reason why I did that is because healthcare is a business. And if you want to be an excellent leader in the business, you have to understand the business of healthcare. So the MBA helped me understand what the business of healthcare is and how it can align IT goals, initiatives, efficiencies around the business and drive better business outcomes for clinical care. Because the IT department is a subsidiary of the overall network, and we support everybody across the board.
Right.
We're not just supporting IT, we're supporting everyone. All those people, it's the operationals, the primary care, the financials, security, we all are part of those pieces. So for me to understand all the pieces helps me become a better CMIO, the clinical, the IT, and then the business. And that trifecta has made me very confident in my ability to deliver for other CMIO today at Nuvance Health.
That's fantastic. And one of the courses I teach in some of the consulting work, I do this program called Building the Brand Called IT. So you have to brand IT within the organization, just like you brand any other product, whether it's a consumer good or whatever, and have that engaging and trustworthy. So it's surely the MBA helps with that. One of the reasons I wanted to get together is you've done so much work on equity, but it's been in such an interesting area. We always talk about implicit bias. Nobody really knows what it is sometimes until they feel it. But you've been able to identify it, and in some to the country western term, in all the wrong places. So I'm curious how you started bumping into this implicit bias, especially as it relates to devices, and even more especially how it relates to some of the apps that people are using in various levels within the healthcare organization.
Being a CMIO it's 50% clinical, 50% technical, and 100% personal, meaning that you have to remember the patient, and the patient is why we're here, to support them. Understanding what they go through, understanding the lives that they lead, and understanding that because of biases, whether it be explicit racial or just unknown biases that people grow up with from childhood, the impact to a patient will be dependent upon the clinician taking care of that person. So in order to do that, we had to remove those things. Our leadership group, we went through an implicit bias understanding, and we got a cultural understanding of what that was, and really learned a lot about that. And I applied some of those guidelines to clinical workflow practice, how to remove those implicit bias. Don't assume the patient is XYZ. Find out the truth, get the knowledge, use the data, and use the analytics in order to better understand how you can apply your clinical knowledge unbiased to the patient's outcome. I've collaborated with Dr. Brenda Ayers. She's the Health Equity Director for Nuvance Health. And with her guidance and our IT collaboration, we've developed a workflow to evaluate these technical aspects that are patient-facing, but also clinically reliant upon. So the importance of the combination of the two came out of a paper that she told us about. It was called 2020 New England Journal of Medicine, Hidden in Plain Sight. If you look up Hidden in Plain Sight, it goes about how do you reconsider the race correlation in clinical algorithms. So the work has already been out there. We wanted to take the work and focus it on Nuvance Health patients. In doing so, we broke it down to 8 different clinical areas, of which 3 we made a lot of headway in. One is pulmonary, so spirometry evaluation of patients is different. If the old way was if you're a white male, same height and weight versus an African American male, same height and weight, the outcomes were different. Why? Because it was a coded piece of information of racial index within the algorithm that created the bias. But that bias comes from prior, let's just say, biased research done in the 40s and 50s, early 60s that drove and still remains in some EMRs, not in ours, but in some EMRs that allowed this to be unknowingly utilized in patient care. Another one is VBAC, vaginal delivery after C-section. There was implicit bias to say, well, if you're of a race, you're less likely to be successful in VBAC. And that's not true. Anyone, female, race agnostic, can have a test of the availability to be able to deliver vaginally after a C-section. So those biases, and those were trained biases in the literature, on rounds, in the residency programs, that we have to start from the beginning, learn what not to teach, and then ensure that the educators doing the teaching are updated on the current state, and then have our educators move forward with those as well.
I wanted to ask you as a follow-up to this. I mean, we talk about race, obviously. I mean, it's number one. But did you find any biases in any way to the LGBTQ patient, or are there biases that you're finding in these devices? I mean, we're surely seeing it in other things, even just Google searches, things like that. So it's ubiquitous in terms of the web in general. But anything in terms of that kind of diversity that you bumped into?
That's a great question. I think what the bias is that information has been missing since the beginning of time.
Okay.
If you're a different patient, if you're an LGBT patient, doesn't mean you're different in care. You just that information not in your record to treat you appropriately because there's different. That information is important. Just like having a history of pancreatitis, just like having a history of a stroke, you have to have a history of the patient themselves and who they are. Just like if you are a tennis player and you come in with an ankle sprain, we want to know how important it is that you go out and play tennis again. Just like anything else, we have to know who you. So the whole person has to be collected in that information, and that's what the social determinants of health is trying to do. LGBTQ in terms of collecting that information is doing, and there are many states across the country, and now the federal government is requiring us to collect that information. And that's just this year, 2024. We've just started to collect that information. So when you talk about bias, the LGBTQ community has been left out of the data gathering that directly impacts care that we deliver better for them than we know who they are and what their needs are.
Interesting. Much like COVID, I mean, there's no history up until 4 years ago. So we think there is, but 4 years really isn't history, which goes back to a lot of the things that we're seeing right now. No webinar or radio program could be complete without bringing up artificial intelligence and how it's affecting things. But I'm curious from your perspective. We do a lot of focus groups, thought leadership roundtables at Chime. I'm curious from your point of view of if what's happening in AI is going to magnify some of these implicit biases, or is it going to get rid of them, or a little bit of both? I mean, we're seeing some of it in ChatGPT and generative stuff that is by the nature of the output is pretty shocking sometimes, but we're also seeing the positive. What's your experience been in terms of deploying this, and we'll get into the governance part of it after that.
We are very early in understanding AI to extent in the clinical practice. We just started heading up the governance, just began, so we haven't deployed anything yet, but understanding what we're deploying and how to deploy it is a very important part of being successful. Two factors for me in AI is the algorithms and the data. So the algorithms have to be correct, meaning there's no biases. Meaning, like we talked about before, if you have these clinical aspects, and the last factor, the last clinical area that we did have improvement on is EGFR. So electronic glomerular filtration rate. Doesn't matter what kidney you are, whether you're a Hispanic male, African-American male, white male, the kidney's the kidney, it has the same GFR. You don't need to have a racial tone to it. Right. That was the other aspect. So we removed also that bias within the calculations and remapped all those patients as well. And of course, they went on to have the same care they would have if they were non-Hispanic or non-Black. So that's one aspect there too. But that algorithm, drive it forward to AI, is the same thing. If we go now and use an AI engine that calculates EGFR and has the racial percentage in there, we're giving different care because of race. And that is inequality. We have to remove that. So check the algorithms and then check the database that you're using. Because what AI is aggregating billions and billions of bits of data. Where's that data coming from has to be sources of truth. We can't have someone out there favoring one race or one culture or one, etc., putting information in that we are using within our understanding of the clinical practice of medicine. So we rely on our EMRs, we rely on our algorithms, rely on our data lake, our data pools, our data analysts to really ensure there's protections around all of that is unbiased, algorithms are accurate. And then we're always testing. Once we get started with our use, it's not just turning it on and see what happens. It's turning it on slowly, understanding what happens, and ensure that equity is provided after we do turn on AI.
I'd like to welcome you again to Health Stealth Radio, produced in partnership with Chime, Digital Health Insights, and syndicated weekly on Healthcare Now Radio. On this program, we explore the shadows of enterprise and patient cybersecurity. Today's guest is Al Villarin, world-class CMIO at Nuvance Health, and we're discussing tequity and implicit bias in healthcare apps and devices. Thank you again for joining us, and thank you again, Al.
It's always interesting to see who these governance dream teams are. I mean, governance is cool again. It used to be you rolled your eyes over and you said, "Oh my God, don't even say the word in a meeting," because we know people are going to be working on their iPhones. But I mean, when you see what's happening with governance right now, it's actually a pretty exciting area to be in. And it's also very contentious. So we're always looking to explore who the governance dream teams are, because you've got some of the people that are in radiology who might say this really isn't new for us at all. We've been doing this for years, and then we have the people that are in clinical decision support saying, "Oh my God, keep this away from my patient's decisions. I don't trust the thing because it's going to hallucinate." Then you have someplace in the middle that are the robotic process automation people who are saying, just get these repetitive tasks out of here. I'm sure you're dealing with all those constituents, and especially the toe in the water seems to be repetitive tasks and more mundane tasks that really are easily solved. Is that what you're experiencing?
Absolutely. Part of my capstone project is to evaluate the utilization of AI in terms of understanding creating a predictive model to understand if Dr. Cutitta may go on to have a burnout episode in the future, depending on your behaviors and your interactions and the workload that you have. We're looking at three major factors. We're looking at a personality yourself, we're looking at the workflow environment, we're also looking at behaviors that we can determine through our analytics within the EMR itself, and look at your behaviors versus others who don't have behaviors that may be persistent or consistent with early burnout. There's a lot of research back there. So we're looking at that to bring that into our EMR coming up this summer. The governance is I think, multifactorial. Besides IT, you have IT clinical informaticists who are, of course, are very interested in utilizing this at the bedside. The IT security, which are willing to work with us and keep it safe so we can work in our environment so that external threat actors aren't impacting our just PHI, let alone anything with the algorithms. Compliance, of course, legal, business analytics is a big piece. We have a separate business analytics group that handles all of our cloud collaboration of data and understands where that data lives and how we can create access to it from a clinical perspective as well as operational perspective. Legal, strategy, and patient advocacy. Patient advocacy is a very important piece. Before we turn anything on, does it impact patients equally and have them have a voice in that understanding of how AI? Because we need to get the trust of the patient. I mean, without trust of the patient will say, no, I don't want this in a clinical practice. And that will stop each interaction with a clinician and patient and create distrust. We want to increase that trust. So we need the trust of the patient and the trust of the clinicians to coincide and be in synergy so we can create trust in AI for healthcare.
So you're saying at some point there is a patient co-design aspect to this in terms of the work you're doing?
I believe so, because it has to be an understanding of society. People, it's interesting. People won't let you share their information protected in a health information exchange to allow other clinicians to take care of them if they show up at another emergency department. But they're willing to give their information to Amazon, anybody else out there when they want to purchase something or put their information online, et cetera. So there's a disconnect there on what's important, and health should be the prime directive is protecting patient information, but also providing best care possible with the knowledge we have of the patient.
Sort of interesting how that landscape is changing. As you know, in some of my previous work and where we bumped into each other, I did the footprint and the blueprint for a hospital at home conference. So how that data collection aspect is going to change as the care moves out of the bricks and mortar and into the home. And going back to your point of knowing the patient, the people that we've talked to in hospital at home of saying this is the first time I've really been able to see truthful social determinants of health. Because when we ask them on the inventory form, when they check into the hospital, do you eat cornflakes? Do you eat junk food? They say no. But when I go into their home and open up the closet, I see Cheetos and popcorn. And so they absolutely love it. So it's a new kind of data that's going to be coming from places that we never had it before, including your grandmother who's helping take care of you, and your wife and children, and the dog who's there as well.
Right. Again, we're a trusting race. Humans, we are trusting to start out with, but for somewhere along the line, we became distrustful and negative in terms of interacting with others around that trust factor. I believe for me, trust is a very important part of healthcare. As an emergency physician, when I was practicing, going to the bedside, the first 20 seconds of interaction with the patient or family or child definitely created the sense of success in treating that patient moving forward. So if you don't have that immediate trust or speak their language, understand their culture, respect who they are as a person, you will never get past the first door to take care of their family, take care of their illness, take care of their future. And that's a big piece of healthcare today, that we've lost that interaction. I believe we've lost humanity to some extent over the technology. And as a CMIO, I have to always focus on the both being balanced to deliver what we deliver today from our perspective.
Your timing is perfect, because I'm just in the process of launching a new product at Chime called the Compassion IT, or if you look at it in words, Compassion It. So we're looking for that intersection of compassion and technology, as opposed to just, not that it's bad, but just looking at burnout and things like that. How is IT part of the solution, and how is it part of the cause? You talked about language, so I just want to go off a little bit onto, the age-old percentage where people say 80% of the data in healthcare is unstructured. And because of artificial intelligence, because of scripting technology, ambient technologies, I mean, that's become more and more important. But and we're always suspect because of AI to see how that unstructured data is being turned into true insight. So how would you characterize the capture of unstructured data in your organization? And what are you doing to make sure that you get as much of it that you can use as possible?
I think there's two sides of the same coin. One is the end users. When they put information in that's just a text response, et cetera, it's our fault that we designed it that way so they can put other or not specific answer. So that's unstructured in a way. But we have moved further and further down the development algorithm to say, okay, here are the 4 or 5 choices you have to say no to a flag or an alert. That became, now we have the structured choices there to kind of not force feed, but help them understand that we need this data to be accurate and not just being out there as a text message or something we can go. The other side of the coin is building it on our side. So going back through all the power plans or algorithms, order sets, and understand where there are vulnerabilities, where we can close that gap of data coming in that really is unstructured, and work with the intake, whether it be registration, the forms. We have an application that sits outside our domain that we send the patient. They put in their own information. That's all structured data coming in.
Right.
Pre-meeting that goes and then feeds our EMR. So we're hitting it from the patient input side, we're hitting it from the clinical input side, and we're hitting it from the informatics side to build specific and better algorithms to support direct information coming into our data lake or our lake. That build then from all those sources becomes combined within our unified cloud base that allows then specific access for research, clinical evaluation, predictive modeling, and predictive financial outcomes as well, because that information is important to all aspects within the space of the healthcare network.
So are there, I mean, if you look down the road a ways, I mean, I would put on conferences for artificial intelligence, cybersecurity, especially artificial intelligence. People get up and start their speeches by saying 5 years ago, this is going to seem, 5 years from now, this is going to seem completely ridiculous to hear this played back. So I mean, if you're looking in the crystal ball, I mean, what are some of the things that you're starting to see bubble or that you expect to see bubble that will be data flows that we never dreamed that we would have right now? What's on your, my dream list of what I wish I could have?
That's an impressive list just because patients use multiple portals to put their information, right? So we're talking outside of the hospital, everything from driver's license information that can be scanned on the back to create a registration, use that as information that's important for if you're unconscious on the road. The driver's license has that bar at the back, scan that, get the information, create a registry, find out what the medications are. You kind of create an environment of who Al Villarin is unconscious on the road by who am I, how old am I, what am I taking, medication wise, that kind of thing. So
which you could do for your dog, you could do for your dog, but you can't do it for a human right now.
There you go. See, so why? Well, because access to information is trust has to be a human element. We have to not break that up, help your patients understand that's important for us to take care of you. And then, and everything else that we do in life is understanding who you are as a person. We have to evaluate the person with an unbiased tool. And I think if humans looked at a patient with a bias, then the patient gets distrust. And that's where we are today. If we created an environment that we created an omniscient, unbiased tool and tested it so that everyone's given the same opportunity to put their information into it, that we can aggregate then and create best practice throughout the world or throughout the United States, at least we have control over that. That will give us better understanding of the outcomes of a single person in the process of the greater good. But we're not making that one person less important than anyone else. I want to know the external data influences that patient has been under, but also the internal influences I have from the same patient that we saw in 300 prior visits from other patients within our EMR. Both those areas are important for us because the patient who's unconscious in front of me, I don't know that they're a welder. I don't know they're, a pilot. I don't know they're in cold climates that impacts their clinical outcomes. But we have to know that to be better clinicians. The more information we garner, wherever it comes from, has to be evidence-based and accurate, but also utilizing the technology of the algorithms and AI to provide us the best guidance in terms of doing so. We'll still have clinical judgment. We'll still have some biases that we try to train out of ourselves, but the knowledge that comes in through AI is a benefit for us to deliver for our better care for our patients.
Getting to know the patient doesn't really need artificial intelligence, things like that. I mean, what they did for me was so ridiculously simple. They got a poster board and they collected photos from my family, and they said, "This is Frank. He has a labradoodle. He teaches snowboarding. He's a professor." So every time somebody walked in the room, they said, "Oh my God, Frank, I didn't know you did this. Oh my God, I didn't know you had a dog. I didn't know you like to cook." So I mean, we really don't need sophisticated technology investment that's going to give a CFO heartburn. I'm sort of curious about what the challenges are in getting people to work in this area right now, the workforce, which we hear constantly. So how challenging is it for you in certain areas in the organization that you're in to recruit and retain people? And secondly, a two-part question: what are you doing to inspire innovation? How do you set up a risk-reward structure in a do no harm business to get people to take risks to innovate without feeling that they're going to kill somebody, to put it extremely bluntly?
We're starting to see the benefits of 4 or 5 years ago starting up clinical informatics rotations and fellowships and those kind of efforts. We're starting to see that come to fruition, and hopefully we can garner that within our network and all the networks across the country, because understanding the clinical and AIT together from someone who's trained in healthcare, has the emotion going into healthcare, has a clinical understanding of their training, 5 years, 10 years, whatever it is, but now has the informatics, the technical understanding and training to allow those to combine together. That's the person we need leading the future. That's the
Right.
person we need leading the embedding of new technologies and innovation. As we move, as all of us, Frank, get older, we have younger folks coming in. The young folks have the trust, have the innovation, have the desire to move this forward. We're not working on paper, we're not working on faxes anymore as much. We're trying to get rid of that. But the new generation is now going to lead us into the next 10 years of growth around innovations, forward thinking, applications of trust. Those kind of things are be part and parcel of their practice. From an innovation idea, our academics group has created the Spark Tank, just like an innovations competition, just like other hospitals have done so. And around those ideas, we really promote, give us an idea, just start, give us an idea, we'll help you grow it and nurture it and create the business model around it that will, one, produce an ROI, but also produce the improved outcomes you want to see. May not be financial, but that financial translates into better patient care, reduction of return on 30 days, reduction of length of stay. You can impact it in many different ways. Utilizing AI is going to be another factor we're going to address as well within that innovation group. How does AI impact you, the employee at Nuvance Health, from a financial person, operations person, strategy person, clinician, whoever it is? It's the same engine, but you're utilizing it in different ways. And that's where I think we're going to grow and nurture that farm of different use cases that will then focus on 10 or 15 that will really make a difference for the future of Nuvance Health.
Al, this was great. Really appreciate it. Thank you for coming to Health Stealth Radio this week. Please tune in. We have a weekly program on the shadows of cybersecurity, both on the patient side and the enterprise side.
Thank you for joining us today in the shadows for this episode of Health Stealth Radio with Frank Cutitta. If you like the program, please be sure to share your comments on our social media sites, or feel free to contact us with suggestions for new and stealthy show themes. We look forward to welcoming you again for our next broadcast. In the meantime, stay safe out there.